Question Sandancerson antithrombotic therapy and revascularization strategies in non-ST elevation acute coronary syndrome, NSTEACS accompanying document of 2020 ESC guidelines for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation. Session 2. Question 11. What are the high-risk criteria for long-term treatment with a second antithrombotic agent besides aspirin? Criteria for a high thrombotic risk are the presence of a complex coronary artery disease based on clinical judgment and at least one further criterion among risk enhancers or technical aspects. Table 11. Risk enhancers include diabetes mellitus requiring medication, history of recurrent infarction, any multivessel coronary artery disease or polyvascular disease, coronary artery disease or peripheral artery disease, premature, less than 45 years, or accelerated, new lesion within a 2-year time frame, coronary artery disease, concomitant systemic inflammatory disease, for example HIV, systemic lupus erythematosus, chronic arthritis, or chronic kidney disease with estimated glomerular filtration rate 15 to 59 ml/minute/1.73 m2. Technical aspects include at least 3 stents implanted, at least 3 lesions treated, a total stent length greater than 60 mm. A history of complex revascularization, left main, bifurcation stenting with greater than or equal to 2 stents implanted, chronic total occlusion, stenting of last patent vessel, or a history of stent thrombosis on antiplatelet treatment. Table 11. Question 12. Does it make sense to continue parenteral anticoagulation therapy after PCI? No, there is no supportive compelling evidence. A prolonged parenteral anticoagulation after PCI has never been shown to reduce peri-procedural ischemic events while it may increase the risk of bleeding. Thus, all the respective drugs should be discontinued immediately after PCI except for specific clinical settings such as the confirmed presence of left ventricular aneurysm with thrombus formation, the presence of a mechanical valve, or atrial fibrillation requiring anticoagulation, which is usually done with unfractionated heparin in poor, acute settings. Question 13. Is there any evidence for dropping aspirin in the early months after PCI in NSTEACS patients? Yes, there is now evidence. The randomized Twilight, ticagrelor with aspirin or alone in high-risk patients after coronary intervention, trial examined the effect of ticagrelor alone after a period of 3 months dual antiplatelet therapy versus ticagrelor plus aspirin with regard to clinically relevant bleeding among patients at high risk for bleeding or ischemic event who had undergone PCI. The primary bleeding endpoint was significantly reduced by omitting aspirin with a significant interaction according to ACS at presentation. The trial was not powered for the composite endpoint of death from any cause, non-fatal MI, or non-fatal stroke. Anticoagulation and antiplatelet therapy. Question 14. A patient with atrial fibrillation and a mechanical prosthetic heart valve, treated with a vitamin K antagonist, VKA, is admitted with suspected NSTEACS. Coronary angiography is planned. How do you manage anticoagulation? Coronary angiography can be performed on vitamin K antagonists since interruption and bridging with parenteral anticoagulation is associated with increased thromboembolic episodes and bleedings. The radial artery is the default vascular access. In the case of PCI, additional low-dose parenteral anticoagulation, for example unfractionated heparin 60 IU/kg IV class 1 recommendation or enoxaparin 0.5 mg per kilogram IV class 2A recommendation, should be considered if the international normalized ratio is less than 2.5, section 5.3.1. Question 15. What about if the patient is on non-vitamin K antagonist oral anticoagulant, NOAC. Coronary angiography can be performed without interruption of NOAC using the radial artery as the default vascular access. In the case of PCI, additional low-dose parenteral anticoagulation, for example unfractionated heparin 60 IU/kg IV class 1 recommendation or enoxaparin 0.5 mg per kg IV class 2A recommendation, should always be considered, regardless of the timing of the last NOAC administration. Section 5.3.1. Question 16. A 72-year-old male with non-ST elevation MI, NSTEACS, underwent PCI with a drug-eluting stent, DES, in the first obtuse marginal branch. He has permanent non-valvular atrial fibrillation with a CHA2DS2 VASC score greater than or equal to 1 and is on vitamin K antagonist. How would you optimize the patient's anticoagulation? NOAC should be used instead of vitamin K antagonist at the recommended dose for stroke prevention because of its superior safety profile, for example lower bleeding risk. Given the implantation of a single DES into a vessel with limited myocardium at risk, dual antiplatelet therapy should be administered up to 1 week in addition to NOAC. Thereafter, dual antithrombotic therapy with NOAC and single antiplatelet therapy, by preference clopidogrel, should be administered up to 12 months, Figure 8, Section 5.3.1. Question 17. A 64-year-old female patient with non-insulin-dependent diabetes mellitus and permanent atrial fibrillation, CHA2DS2 VASC score greater than or equal to 2, is admitted for a NSTEACS. She underwent an early invasive coronary angiography with PCI of the distal left main coronary artery with 2 DES. How would you manage triple antithrombotic therapy, TAT? This patient is at high thrombotic risk given the presence of diabetes and the complex coronary anatomy, Section 5.1.4, Table 11. The theoretical bleeding risk is low according to the Hasbled score of 1. Triple antithrombotic therapy consisting of a NOAC at the dose recommended for stroke prevention associated with dual antiplatelet therapy, aspirin and clopidogrel, should be administered up to 1 month. Thereafter, dual antithrombotic therapy with NOAC and single antiplatelet therapy, SAPT, preferably clopidogrel, should be administered up to 12 months, Section 5.3.1, Figure 8. Question 18. A 72-year-old female patient with hypertension, non-insulin-dependent diabetes mellitus, and atrial fibrillation treated with NOAC, last dose taken 6 hours before hospital admission, is admitted at 12 a.m. for NSTEACS. She is free of angina at admission. Your resident asks whether we should postpone invasive coronary angiography to the next morning. What is your answer? This patient should receive aspirin at the initial oral loading dose of 150 to 300 mg, or 75 to 250 mg IV, and a proton pump inhibitor, additional low-dose parenteral anticoagulation, for example unfractionated heparin 60 IU/kg IV class 1 recommendation or enoxaparin 0.5 mg per kg IV class 2A recommendation, and sent to the catheterization laboratory for an early invasive coronary angiography within 24 hours, which in this case may be best during the afternoon. We may consider postponing to the next morning if the catheterization laboratory is not available and transfer is needed to a hub hospital, Figure 9. Question 19. PCI with DES implantation of the mid-LAD coronary artery is performed in the afternoon. Your resident comes back to you and asks how to manage antithrombotic therapy thereafter. Your answer is that a loading dose of clopidogrel, 600 mg orally, should be administered as soon as the decision for PCI is made. Then comes the decision of triple antithrombotic therapy duration. the high bleeding risk of the patient, has bled score greater than or equal to 3, seems to outweigh a moderately increased thrombotic risk, section 5.1.4. You explain that triple antithrombotic therapy is recommended for up to 1 week post-PCI, followed by dual antithrombotic therapy, NOAC with single antiplatelet therapy, preferably clopidogrel, for up to 6 months, section 5.3.1, figure 8. Question 20. Your junior doctor keeps asking questions and whether ARCHBR is better than any usual score for bleeding risk assessment. What is your answer? The ARCHBR is an alternative tool to assess the bleeding risk, Table 7, in patients undergoing PCI. It represents a pragmatic approach that includes the most recent trials performed in high bleeding risk patients who were previously excluded from clinical trials on dual antiplatelet therapy duration or intensity. In the presence of high bleeding risk criteria, i.e. when one major or two minor ARCHBR criteria are met, an NSTEACS patient treated with stent implantation should discontinue P2Y12 receptor inhibitors after 1 week. In NSTEACS patients treated with vitamin K antagonist, clopidogrel alone should be considered up to 12 months, class of recommendation 2A, level of evidence B. ARCHBR criteria may be difficult to apply in clinical practice as several of the criteria are quite detailed. However, this score is comprehensive, robust, and has been validated. Thank you for watching.